Very good afternoon to everybody, and apologies for the delay due to inadvertent reasons. And we will be talking about very important issues today, particularly about three important guidelines which are relevant from clinical perspectives, and these are going to impact a lot of pediatric endocrine conditions, including short stature and growth hormone deficiency, including evaluation and management of hyperandrogenism and Turner syndrome. So guidelines are integral part of our clinical management, and every which come up. Now, whether we need to follow a guideline, whether every guideline is applicable to us, and what is important is something which the clinician needs to understand. So we should review a guideline before blindly following it, because we need to look at whether it's really evidence-based in that scenario or not, whether there are issues in terms of other issues in terms of development of those guidelines, in terms of whether they represent a state of the art scenario in terms of research, whether they just share the expert opinions, and it may often be difficult to evaluate. So we need to interpret the guidelines in a proper fashion. We will be discussing about these three guidelines as discussed. All of you can go and have a look at our website, learning.growsociety.in, along with our learning portals, which provide validated courses related to pediatric endocrinology, including training programs. We run multiple online programs in terms of pediatric endocrinology, along with publications and mobile applications. So we'll talk about three important guidelines: the long-acting growth hormone, which has recently been published in JCEM, Turner syndrome guidelines, which has come up from multiple organizations, and PCOS, also the International Society guidelines. So to start off the process, we'll invite Dr. Vibha. And just before that, just as we are discussing about, what do we look in guidelines? So first of all, you have to look at how much literature has been reviewed. Now, every guideline tells us what all papers they have looked into, how long back they have gone into, and how extensive had then workup been. And then how do we grade the evidence? So we need to understand there are different grades of evidence, what being most important. So a randomized controlled trial is considered to be the best evidence, and the expert opinion is the least important. So we have to understand which recommendation has got what grading. So I think you people can emphasize on that aspect as well, as to what grading was given to that particular evidence. Of course, long-acting growth hormone is not something which is very, very commonly researched also, so we will have less evidence there. Then weightage is to be given whether there is any bias in that regard. Also remember that guidelines are just there to guide us. They are not just to make sure that we just follow a straight line. So we do not use them in a dictatorial fashion. We should individualize management and based upon which overall environment we are living. So we just not need to blindly follow the guidelines which are applicable for one group of individuals, which may not be feasible for our scenarios. So I'll start off with the first guidelines. Dr. Vibha will talk about long-acting growth hormone.
Thank you, sir. And good afternoon, everyone. So, starting with the long-acting growth hormone guidelines, we all know we have been using widely the short-acting growth hormone, which is the only treatment available for the short stature. But the long-acting has come up in the market, and consistent statements have been given for this long-acting growth hormone. So the question is, why do we need long-acting growth hormone if we have short-acting growth hormone in the market, and it has been used in all the patients of short stature? So the problem with the short-acting, because it requires multiple injections, which are quite painful, and it adds burden to the family. It is quite expensive. So these all three problems leads to poor adherence. To cope up with this poor adherence, long-acting growth hormones have been developed, and this consistent statement is being published in the JCM journal, and they have studied three long-acting growth hormone. One is somapacitan, which is formed by increasing its albumin binding growth hormone. This activity is increased by increasing binding its to albumin. Another is somatogen. Here the HCG is binded to the growth hormone, which increases its half-life. And the third growth hormone that they have studied is the lonapatch somatotropin, where the pegylation is being used for increasing the half-life of the growth hormone. Here they have studied the non-inferior, that is means it is quite equivalent to the short-acting growth hormone, and they have studied the height velocity at 1 year. These consensus statements have been published on the basis of phase 3 trials of these growth hormones. So starting with the case scenario, we have this 8.8-year-old boy who presented with a short stature. Height was less than minus for standard deviation, and weight minus 3.38. He was diagnosed as growth hormone deficiency, and he was started on the daily subcutaneous growth hormone. The dose was started with the low dose of 25 microgram per kg per day, but growth hormone was stopped due to multiple daily painful injections. So the consent statement has clearly given the criteria who are the candidates appropriate for starting the long-acting growth hormone. And these are most important because those patients who have increased risk of poor adherence to daily growth hormone, like teenagers and painful injections, daily injections. Those who have to take the multiple medications to this decrease the drug-to-drug interactions. So this long-acting is better. The children who have neurodiversity, including autism, ADHD, or other neurological or behavioral disorders. The children who have fear and anxiety associated with injections, even the parents who have fear and uh, it's difficult for them to give the growth hormone injections daily, and the children who have more than one home because it is difficult for the supply growth hormone to each and every of their location. Those who travel frequently, like those who are involved in camping trips, extracurricular activities, the long acting is a better option. And those who families are social disadvantaged and for whom growth hormone is an additional burden.
So these are all more like a expert guidelines
Expert,
to what
yes,
they're
sir.
thinking that they will be
Because this is
beneficial.
these are given on the basis of just phase 3 trials.
So this is more like a common sense
Sense, yes,
that
sir.
we should be given.
Yes.
So they don't recommend they should be offered to everybody. Like if you talk about insulin pumps,
Sir,
what they say is that
yes,
it
sir.
should be every child should be offered insulin pump.
Sir, they have mentioned that it should be given to all, but who are the
Priority.
if we say ki supply and the first
Priority will be there. Priority should be given to these.
priority should be given to those. And those who are doing well and those do not have any problem with the daily, they can go with the daily. There is no problem. Now, the patient, those who were not included in this published trial, were those who, the cancer survivors and the intracranial tumors. Here they have mentioned one thing, like in the daily growth hormone, we start it generally after the 1 year after completion of the therapy, where they have suggest that it can be started within the 6 months after the last treatment of cranio. In the Prader-Willi, it could be considered in the, but in the very young children, they prefer to avoid it because in the initial 1 to 2 days, it could cause hypoglycemia. And it has not been they have not studied this SGA, idiopathic short stature, Turner's, Newman's, and chronic renal disease in this published trial. So they have talked about the doses as well. They have compared and studied the doses. If we go by this lonapexometotropin, dose 0.24, somapacitan, which is the Novo Nordisk product, it is 0.16 milligram per kg, and somatrogen 0.6. So all the three have different doses. Their half-lives are different. And coming to the devices, lonapexometotropin is a auto injector. It comes in the cartridge form, and while the other two comes as a pen form, like the daily growth hormone. Storage coming to all needs refrigeration, but they can be stored at the room temperature for some 6 months for this pexometrin, and 72 hours and 4 hours for the somapacitan and somatrogen. They has to be used like somapacitan should be used within the 42 hours of the first use, and somatrogen 28 days after the first use. Now coming to the whether the patient require 2 injections or not, it depends on the body weight. If the body weight is 60.5, in the case of lonapexometotropin, 2 injections are required. But in somapacitan, if weight is 50 and somatrogen is weight is 45 kg, then 2 injections has to be used in these two cases. Now coming to the missed injection, if patient has missed a single dose or two, then the there is a window period of plus minus 2 days in the lonapexometotropin, and in the somapacitan, in both the plus 3 days, it can be given like after within the 3 days of missing the dose. Now coming to the dose adjustment, like in growth hormone, we look for the growth height velocity, this height velocity, and we look for the IGF, and we start the dose on the basis of body weight and as well as body surface area. But here they have used only the body weight, not the body surface area. They have started the lower initial doses based on the ideal body weight in the patients who are obese. So this is the new concept they have used here. And in the
So instead of a BMI or a body
body
surface
surface
area
area,
base, they are talking about ideal body.
body weight in the case of obese. And in the cases, they have started the lower doses in case where there is a severe growth hormone deficiency, genetic or chromosomal abnormalities, renal failure, or the estrogen supplementation is being used. And coming to the target IGF-1 SDS, it has to be kept between the -2 and +2, close to the 0 SDS. And coming to when we have to switch the growth long-acting growth hormone from the daily, they have recommended that the first dose of the long-acting dose should be given like at least 8 hours after the last growth hormone dose. And when we are interchanging between the two long-acting growth hormone, the gap interval should be like 7 days after the last dose of the prior long-acting growth hormone. Now coming to the IGF levels, it has to be taken 4 days after the prior dose. And if the IgM1 levels is at the 4 day is within the normal range, then no adjustment is required. But if the sampling occurs outside the window period, that is after the 4 days, 6 days, 7 days, then the IGF level has to be adjusted according to the product specific correction factor. And they have given a complete table for all the three long-acting growth hormones. Like if it is taken within the 2 days, then some correction factor is used. So in this way, this IGF-1 levels are corrected. As this is just the expert opinion.
Talk about routine IGF measurements in everybody to
Yes.
adjust.
As there's an expert opinion, so definitely there is a knowledge gap. They haven't talked about the effect of the long-acting growth hormone on the body composition, cardiometabolic changes, adult height outcome, and what will be the effect of the elevated and peak and low trough of the IGF levels. They talked about the intracranial, but the trials has not been done in the patients with intracranial tumors and very young children. This is unknown, the impact of long-acting growth hormone on the dose requirements for the glucocorticoid and the thyroxine. And what will be the effect of the long-acting on the bone health in adults and with open this epiphysis is still not under the trial. The data is also lacking for the pediatric non-growth hormone deficiency states like SGA, idiopathic short stature Turner's, Prader-Willi shock deficiency. So that's all. So these are just
more or less. This is more like a review article sort of a thing.
yes, sir.
They mention it like a guideline,
Concept,
but this is more like a sort of a review article.
not even mentioned like the increase in the or what
How much height is there?
Yeah. What?
Because if you look at it, the data is very limited. And data predominantly overall the somapacitan and somatogron are the ones which are available. But then there is some debate about that. But it does give us some perspective. I think what are the three key messages you would like to give?
Sir, first of all, the one when we are going to transit, the transition has to be like
Yep.
the daily from that. So it has to be like after the 8 hours. And if one is using somatrogen, sometimes the one is not available to, it has to be, second has to be started after 8 days. One is this. One is second one would be this IGF-1 levels when it has to be this collected.
Because you want the mid cycle IGF,
Yes,
not the pre or the post. That is important.
And third is definitely it is the daily is if one is comfortable with the daily injection, so one should not be pushed for the
Essentially, what you're trying to say, it's a non-inferior product.
non-inferior.
It does not mean that it's a superior product.
Yes, sir.
The only thing when it is superior is that you need to give once a week. That is the
Yes.
advantage.
Yes.
So that is something, so you have to look into all the factors.
Hmm.
And one of the major considerations in our setting will be the cost,
Cost.
because cost is something which is going to affect it. But otherwise, there seems to be a reasonably safe with a
Hmm.
good velocity. So this is a good overview. We will wait for data to come in to get more information on
Yes.
that. Thank you, Dr. Vibha. So this was an important topic of long-acting growth hormone. We thought we'll just touch base upon, because there is lack of overall consensus as to what dose to use, how to go forward in terms of monitoring, evaluation. But this is more of an expert opinion as we discuss. So we always say when you talk about evidence, it's the RCT evidence is most important, and expert opinion becomes less, because most cases where they have given opinion is not even looking at what sort of treatment has been given. It's mostly general, that who should be given, who should not be given, that sort of approach. Polycystic ovarian syndrome, however, is something for which a lot of evidence is available, and we already had a big guideline which was there. Multiple guidelines are there from the Endocrine Society, from pediatric endocrine societies, and this is something in which there have been a lot of changes in terms of management as well. So, Dr. Alapan will be talking about the recent guidelines with particular emphasis about how it changes our clinical perspectives and in terms of any management. We'll have just a quick look as to what people are commenting in terms of that. Is 2 injections given on the same day? What's the dose frequency? The long-acting GH will be once a week. That will be the preparation. And usually people talk about loading doses also sometimes, that you give another injection at 4 days and that every 7 days is to be given. So Dr. Alapan will talk about guidelines as far as PCOS is concerned.
Thank you, sir. Good afternoon. So I'll talk about the guidelines, which is not recently, 2000, published in 2023. Previous guidelines was in 2018. I'll mainly touch base on the the adolescent part of this guidelines, which the society has been recommended, and also the changes which could potentially change our management in the PCOS. So I'll start with the definition, the ovulatory dysfunction and the irregular menstrual cycle. A question: 15-year-old female child presented with irregular menstrual cycle. Her mother noticed a breast development around 10 years of age, followed by menarche of 13 years. So mother complains about he is having her menstrual cycle in every 35 days. She had other no features of any clinical or biochemical features of hyperandrogenism. So the main question to us was, is there any need for the treatment in this girl, or whether it is a case of a polycystic ovarian syndrome? So let's see what the guidelines says. The guidelines was as before in the 2018, and in the first year of diagnosis, there is no term called irregular menstrual cycle, but after 1 to 3 years, the cycle duration could be between 21 to 45 days. So in our case, this is not a case of a irregular menstrual cycle, as we can see. As well as they had mentioned that if there is any irregular menstrual cycle, the consideration of a PCOS diagnosis should be considered. They had given the similar criteria for the primary amenorrhea, as by 15 years of age, there is no menarche, or post 3 years of telarche. So moving on to the next.
What proportion of patients with PCOS present with primary amenorrhea?
It's very rare, sir. Mainly the presence with hyperandrogenism, like feature like acne are there, hair loss is there. Primary amenorrhea is less, but oligomenorrhea
is very rare. This is an important message basically. So primary amenorrhea in our experience will be like 10% cases. So it's not that the primary amenorrhea is against PCOS.
Yes.
And menorrhagia.
Menorrhagia, the guidelines had not been said anything, but menorrhagia can be considered because the
So they have mainly focused about oligomenorrhea, but you can have primary amenorrhea, menorrhagia, other manifestations as well. So anovulation will be a better term from that perspective.
Also, the increased risk they had mentioned at risk PCOS, that we know that at gynecological maturity of 8 years post menarche, they had mentioned about the similar to the previous guidelines. Moving on to the biochemical investigation that we do, the similar patient having a testosterone value of 75. So is there any need for treatment in this girl, or whether it is a hyperandrogenism? So in this guidelines, there has been some changes. I might not say changes, but rather they had given some information extra about the sensitivity and the specificity of the total testosterone, free testosterone, as well as free androgen index. they had said that free testosterone and free androgen index was the better parameter in comparison to the total one, as it was previously mentioned.
What cutoffs is it?
They have not given any cutoffs in that guideline, sir.
So what do you think because this is more of a, so what exactly is this guideline? You should always start the guideline with who has developed this guideline, who people have been there. So just inform about that also. Which societies are involved.
This is the International Society for PCOS 2023 guidelines, and the authors are, there is a list of numbers of authors
So
are
it
there.
is both pediatric as well as
As well.
adult. So that is why they haven't given a adolescent specific criteria very clearly. But if you go by the previous adolescent criteria, what is the criteria for androgen levels?
Androgen levels of more than 55 testosterone level were
Nanogram per
nanogram
DL.
DL.
So we need to know that the levels are lower for adolescents as compared to the other groups.
So moving on to the next question. Again, the similar child has started on the basis of this criteria, the combined oral contraceptive pill, and referred to a pediatric endocrinologist. So how to go further to check for whether she has a hyperandrogenism or not? The similar guidelines are saying the similar thing. OCP should be withdrawn for 3 months, and then we have to go for the check for the androgen level, and during that time you can go for the alternative contraceptive method. But this is mainly based on the adult experience and not for the adolescents.
Many times we have got patients who are already on estrogen progesterone. Then how do you evaluate? So of course, if you look at their levels, what will happen to total testosterone, Dr. Sandeep? If somebody is on estrogen progesterone, it will be high. So you can't use that as a marker. What about free testosterone?
It will be it will decrease.
It will decrease. So free testosterone is the best marker for response to estrogen progesterone. The problem what they're saying is that somebody is already on that, you don't know whether treatment is required or not. Something like we see patient with subclinical hypothyroidism. Somebody has started 25 micrograms. Then what do? You hold it off and see what happens. So what they're saying, stop for 3 months because the effect is typically there for 8 weeks. Generally, when you talk about hormonal effects of estrogen, particularly on SHBG, it's up to 8 weeks. On pituitary function, it will be like 8 to 12 weeks. So that's why this 3 month waiting period is recommended.
So moving on to the other test that previously they had said that role of DHES and androstenedione is there is role, but this time they had mentioned that there is a decrease of the DHES level with age and there is a poor sensitivity. So it is not that good marker as a total testosterone or free testosterone in that scenario. And a future biomarker like 11 oxygenated androgens, they had mentioned about this time's guideline.
No, when you are saying that it's not a good marker of hyperandrogenism, you should also specify that it would be an important marker of adrenal hyperandrogenism. So while testosterone is of course the overall marker, but if you don't do DHEAS, you will not know whether it's a adrenal versus a ovarian one. So yes, for PCOS it may not be relevant, but for hyperandrogenism, because we don't know, somebody doesn't come to you with a label of PCOS. So this will be important from that, but yes, of course, testo is better. And androstenedione, overall, what do you think is the role of androstenedione? Nimisha?
Convert to estrogen.
It's converted to testosterone basically, but it is supposed to be a marker of ovarian function. But it is also produced by adrenal, so it's the least important investigations anyway. So in our armamentarium, we don't do androstenedione. We would do DHEAS, which is important, and 11 oxygenated androgens will be some good criteria to look at, more specific and sensitive markers.
Yes. So regarding this DHES, they had further classified that could be the differential diagnosis when we can go for this DHES and other levels. Like they had mentioned about the testicular androgen producing tumor, Cushing syndrome, CAH, ovarian hypothecosis, or any other cause. When we are not thinking about the PCOS, then we can go for the DHES level. And
but when will you not think of PCOS? PCOS is a
diagnosis of exclusion.
So you have to think of everything else before you think of PCOS. So that becomes important. So have they said that you don't need to evaluate for anything else, you label PCOS?
No, sir. They said when there is a high testosterone testosterone levels are inappropriately high for the level of PCOS.
So anybody who has, no, so I'm just asking. So do they say that you don't need to exclude all these before labeling PCOS?
No, they said when there has a high testosterone level, But the testosterone level is inappropriately high for the level of any hyperandrogenic.
So a girl whom you're labeling as PCOS, you don't need to do a DHEAS at all, according to this guideline.
They are saying that go for the first testosterone level,
Yes.
either total or free.
Yeah, yeah. So testo is high.
Then matlab, they are said that DHEA could be done, but it is a second line one. Matlab, they have not mentioned it is could be a part.
That's a bit confusing. So basically, what your message should be that of course PCOS is there, but PCOS is unexplained, persistent hyperandrogenism of ovarian organ. So first of all, you have to prove that this is hyperandrogenism. Of course, testosterone is important. You have to say it's ovarian origin. That means that you have got whatever levels you're looking at, maybe other parameters, and then very importantly is unexplained. So you have to look at all other possible causes. So that becomes important. Of course, if your testo is more than 200, you will start thinking of adrenal tumor right away. But my point is between 60 to 150 also, you cannot just say that I don't look into prolactin, TSH, DHEAS, cortisol, they become important.
So moving on to the clinical part, they had given the similar guidelines that acne both present in the adolescent as well as adults, hirsutism also present in both, but they had not mentioned about the hair loss. Probably isolated hair loss, they had not mentioned about it. One important importance is that they had mentioned about the hirsutism, that an isolated single hirsutism with a significance can be considered as a clinical features of polycystic.
Isolated means generalized or focal?
So generalized.
So generalized hirsutism beyond a score. Of course, that's important. But do you think here in Indian adolescents, what is your experience about the alopecia or hair fall? So what are the major cutaneous manifestation of PCOS that you see, Dr. Vibha?
Definitely, but hirsutism.
Hirsutism is there, acne is also there, but alopecia is particularly common in Indian setting. So these cutaneous manifestations will vary according to the region that you're looking at. If you talk about people from, let's say, western part like Punjabi and Sindhi, they will have much more hirsutism as a major thing. If you look at northeast and that sort of region, they will be mainly acne will be there. And alopecia is more common in Indian setting compared to the other settings. So this, you cannot say that alopecia is not a thing. Yes, but they will also have other features.
There in the 2023, they also asked about the monitoring of these symptoms when on the treatment, whether these symptoms are increasing, decreasing, to look for the treatment effectiveness. For the hirsutism, they had mentioned about the Ferryman-Gallwey score, and for the alopecia part, they had mentioned about two scale. One is Ludwig scale, another is Olsen scale. But
what is the pattern of alopecia in PCOS?
It's an androgenic alopecia.
So
the Christmas tree like appearance.
Yeah, so that's what you're looking at in between. That will be there.
But this time they had modified the term alopecia and said it is a female pattern of hair loss in comparison with the previous.
So they don't want to use the term,
alopecia.
politically correct term.
Now moving on to the USG ultrasound therapy and polycystic ovarian morphology, the best parameter as it has been described previously was follicle number per ovary. For adults, they had mentioned for the transvaginal approach. Here, a new marker of follicle number per section has been given because in adolescent population, it is very difficult to do transvaginal approach. So we have to rely on the transabdominal approach. And in that approach, it is very difficult to get the whole ovary picture at a single section. So per section, follicle number has been an important marker. The volumes are similar, ovarian volume more than 10 millimeter with a FNPO of more than 20. For the follicle number per section, they had mentioned about the more than 10 follicles per section. There is no ultrasound guidelines for the adolescent as it was previously mentioned in the guidelines.
What is the role of ultrasound in a girl with in a adolescent with PCOS?
First of all, sir, it doesn't add to the diagnosis.
No, what's the role? What's the benefit? I'm talking about
we can look for the other any pathologies present or not. Like
yes.
When we like to exclude other adrenal or ovarian.
So, ovarian tumor, which is extremely rare. Anything else?
CHV, it's not that.
So you're wanting to look at endometrial hyperplasia. That also can be an important thing. So if that is the reason why many gynecologists will be getting a ultrasound done, this not to look at the ovarian morphology. The only role of PCO morphology is to predict the likelihood of persistence of hyperandrogenism beyond those 5 to 8 years. So it's not recommended. So it's very, very clear. That's a very important point that you put down. Carry on.
So moving on to the new portion of these guidelines, the previously in 2018 guidelines, they had said that serum AMH levels should not yet be used as the alternative for the detection of PCOS or a single test of the diagnosis. But this time they had said in adults, it can be used as a parameter for the PCOS diagnosis. As well.
So what level of AMH are we talking about?
Yes, sir. This is the reason because this is an evidence-based recommendation. Still, the recommendation is not that high, 3+. It is a not strong recommendation because of this cutoff is not yet defined in the adults, so they had not given
And
any
adolescents, because see, basically, what is AMH? A marker.
ovarian reserve.
In this case, not ovarian reserve. It's a marker.
Number of small follicles.
It's the crude marker of PCO morphology. So what you're seeing on ultrasound is being reflected in your biochemical test of AMH. AMH is being produced by small growing follicles. So if your AMH is high, you've got more small growing follicles. So as PCO morphology is more important in adults, AMH is better marker in adults, but in adolescents, AMH will be anyway high. So it's not going to be very, very helpful.
Some guidelines they had been reviewed and they had found the cutoffs but not recommended. Like in adolescents, the cutoffs are less than 60. And in adults, less than 100 cutoffs they have been given, 25 to 100.
Most of these guidelines you're talking about, there will be some studies, not the guidelines, Mane. And these are like, there are a lot of methodology issues that how do you define PCOS as the gold standard? How do you define normal? When you say 20% of PCO morphology, how do you define which is normal, which is abnormal? So that is why it's not going to help out. So the hallmark of diagnosis of adolescent PCOS are two things.
One is the hyperandrogenism.
Yes.
And clinical
and ovulation.
Ovulation.
So you don't talk about PCO morphology, AMH, it's the same thing. Carry on.
So moving on to a new part, they had mentioned about the ethnicity that some populations may have a higher risk of developing PCOS, especially the Southeast Asian population and Eastern Mediterranean regions.
Yeah.
Now moving on to the complications. Previously in 2018, they had said that there could be a risk of cardiovascular mortality in cases of PCOS, and we should screen. But this time they had recommended for that it is a known marker for cardiovascular death and cardiovascular diseases. So they have recommended for screening. For screening purpose, we have to go for the lipid at the baseline, and based on the we have to go for the repeated test and BP for annual measurement in this scenario. For the glucose, previously they had said that 3 tests, OGTT, BS, HbA1c, 3 are all recommended, but no one was superior to anyone. They had mentioned about some criteria where we can use OGTT, but this time they had mentioned about that OGTT could be a most accurate test for the assessment of the glycemic status of the PCOS regardless of the BMI.
For every girl who's coming to you with PCOS, what all tests will you recommend them?
So first of all, we would like to confirm that.
So I'm talking about association.
Yes. Association regarding, we can go for the blood pressure measurement. We can see the fasting blood glucose level. We can see. We can go for the blood glucose level in doing OGTT level. We can see the other hormonal tests like AMH.
No, I'm talking about complication. So lipid profile you talked about. Anything else?
Liver
function and sleep apnea. These will be the major things.
So glycemic status at baseline and followed by, based on the risk, we can go for the every 1 to 3 years to see for that. And important, another parameter was obstructive sleep apnea. Previous guidelines in 2018, they had said that there are some correlation with obstructive sleep apnea and polycystic ovarian syndrome, but this time they had said that it has a higher prevalence in cases of PCOS, independent of the BMI status. And so this time, all the women should be screened presenting with PCOS. For adult, they had asked for a Barlin questionnaire. If questionnaire is positive, then we can go for the sleep study and followed by treatment. Another important factor that is endometrial hyperplasia and PCOS. Previously, endometrial carcinoma, the chance of endometrial carcinoma was higher. It was known. It was given in the 2018 guidelines. This time, they also mentioned for the endometrial hyperplasia should be a important parameter. If hyperplasia is present, it is also a risk factor for further developing endometrial carcinoma. The additional risk factor they had mentioned about the persistent prolonged amenorrhea, obesity, and endometrial persistent thickened endometrial thickness. Important new criteria for the additional is type 2 diabetes they had mentioned in the 2023 guidelines.
So that is why you need to be very sure that you don't want unnecessarily amenorrhea lasting for a long time, because wherein you will have uncontrolled. So how does amenorrhea predispose to endometrial carcinoma?
The hyperplasia of endometrium.
Because you have got lack of which topic?
Yes.
Progesterone is not there, so it's just proliferating. That becomes important. So that's why that ET. So somebody who has amenorrhea, definitely for a long time, you should get an ultrasound and see how thick the endometrium is. Do they give any criteria?
No criteria there.
Generally, about 10 mm is considered to be very significant, and then you may even think of other procedures.
That said, some gynecological societies guidelines you should follow. FIGO, I think that the guidelines should be.
But about 10 is significant.
Moving on to the familial risks and PCOS, and this is also new to this guidelines that healthcare professionals, fathers and the brothers of the women with PCOS have an increased risk of metabolic syndrome, type 2 diabetes, and hypertension, and this evidence-based recommendation was there. But no routine screening has been done because it is only an observational part. There has been no clinical trials have been seen in these cases.
There seems to be a paternal inheritance partly involved, which is a known phenomenon for PCOS.
Moving on to the next, the psychosocial aspect. I will not go details into this, but they had talked about various aspects of the psychosocial impact. And in these guidelines, they had given the importance on the psychosocial aspects of the PCOS, mainly on the quality of life, depression, anxiety, psychosocial issues, and body image. So these guidelines have mainly talked about the psychological, the therapies we should give when the child is, the adolescent is very much worried about their body image. He is having depression or anxiety. We should go for the first psychological therapy in terms of cognitive behavioral therapy, followed by pharmacological therapies could be given, which is mentioned in these guidelines, which are not there in the previous guidelines. Moving on to the management part, the lifestyle management was similar, apart from one part that has been already discussed about the weight stigma. The child or adolescent should be counseled, and healthcare professionals should be aware about that weight stigma, that how it affects the day-to-day life of a child, and it should be counseled with parents as well as the children in a proper manner. Regarding the diet, there has been no change in the diet. It should be individual preference and the cultural needs. But previously, the guidelines said a low calorie diet, means the calorie should be restricted to get a weight loss. But this time they had said about the sustainable balanced eating rather than a calorie deficit diet to maintain the weight as well as a loss. Regarding the physical activity, adolescents should be aimed for at least 60 minutes, which was there in the previous guidelines. Adult have the similar kind of physical activity pattern, which was there in the 2018 guidelines. Moving on to the non-fertility pharmacological management, the previous recommendations about oral contraceptive pills is recommended here also. And in this guidelines, there has been seen that there is no role of any high dose versus any low dose therapy in combined oral contraceptive pill. In this guidelines, the new is the use of progesterone only contraceptive pill for the endometrial protection, which was not there in the previous guideline.
But that could obviously not for adolescents, because their hyperandrogenism is not going to be taken care of. This will be more likely to be PCO morphology with an ovulation, where you can use
this. Metformin has been similar recommendation as it has been given in the previously, and they had asked for assess the B12 level.
So every PCOS adolescent, irrespective
They have
of their
mentioned about after one annually, we can look for check for the.
No, metformin for every adolescent they're talking about.
No, they have mentioned about some criteria that BMI is more than 25.
That was for adult in your
In adolescent, they had mentioned for PCOS or at-risk PCOS.
So anybody. So anybody who has, you're thinking of where you're starting E+P, you should give metformin.
Metformin.
That is a criteria. So BMI is not a criteria for
Hmm.
adolescent. That's the important thing to highlight. And even type 1 also may have PCOS. There also metformin will be of role.
The other medication this time they had mentioned about the oral anti-obesity medication like liraglutide, semaglutide, and GLP-1 agonist could be considered in addition. And even they had mentioned in the fertility portion that it may have a role in the prevention of the infertility and other things. One important other medication which was there previously in 2018 guidelines, but was in an experimental way. They had said in 2018 that it can be used in an experimental therapy. But this time they had said that any form of inositol could be given, could be considered in women with PCOS, but its role in the fertility has not been proven yet.
So this is again looks like a how do you read that, understand that statement, Dr. Sandeep? What are they saying? Why should inositol be used? They're saying based on individual preferences. So what do you mean by individual preferences? When you're prescribing a medicine, there's no individual preference. Noting limited harm. So you're giving a medicine because there is a limited harm, just because it does not harming, and potential for improvement. So it's like a very speculative thing. So what do you think about these sort of statements? They may be influenced by the
Yes, maybe.
overall, if you talk about industry, because this sort of statement makes no sense. If you talk about scientific way, you are saying that this is something which individual can decide. It doesn't do any harm. So you can take water, it won't give you harm. There is a potential for, there's no a definite improvement. And what is this criteria which is there, which they mention? The guide, the evidence status.
It is evidence.
How, what is the
It is
strength?
strong evidence. It is just below the strong evidence.
So it's a very, very vague scenario from. Yeah, carry on. So inositol, we don't use inositol. That's what we are saying, because the evidence is very lacking. The last guideline said should not be used. From there, this has come up saying that it may be considered. So it's a very vague sort of a scenario. But metformin definitely
As a rule.
is this. How do inositols work?
That will improve some metabolic.
How? What are inositols?
Inositols are muscle products from.
So they are supposed to be the messengers of metformin action. How does metformin, insulin act? Insulin acts through all the pathways, and then some inositols are found, myoinositol and those things. Now, my point is, when you give something orally, how is it going to go inside the cell and start acting there? That's the biggest question. So that's a big problem. So inositols are supposed to be the in the intermediary pathway of insulin action. So even if you don't improve insulin sensitivity, you give inositol, that will improve your insulin action. That's the concept. But then there is like, it's like giving various collagens for osteoarthritis. How is it going to go to the joint, particularly getting deposited? So that's the, it's not a biological feasible option. Carry on.
In 2023, they had mentioned about the mechanical laser and light therapies for the removal of the unwanted facial hair. They had not mentioned about any oral topical medication in this new guideline. Regarding the bariatric surgery, they had mentioned that it could be considered as for the improvement of the weight loss, hypertension, and other metabolic parameters, along with hirsutism and other complications of hyperandrogenism. So moving on to the fertility pharmacological management, which is they had given a similar kind of guidelines from the previous one. They had, for the ovulation induction, they had chosen clomiphene citrate and metformin over placebo. But the best therapy they had said is the letrozole over the clomiphene citrate. And they had also seen some combinations, but they are all secondary to the letrozole. Moving on to the gonadotropin therapy, previously it was not in the first line therapy, but this time they said it can be used in the first line therapy when there is a failure or resistance to the clomiphene citrate or metformin in that scenario, and some modification of the cycle follicle length of more than 14 millimeter. Laparoscopic surgery, it is still in the second line guidelines, second line therapy in cases of 2023 guideline. In vitro fertilization, IVM, they have mentioned about more preferred where there is a risk of ovarian hyperstimulation syndrome, and freeze-all strategy as a new to the addition of the.
What is IVM?
IVM is in vitro maturation. So they collect the ovum from the mother, make it fertilize outside, and they put it inside.
And why do they recommend freeze-all strategy?
Because there is a chance of ovarian hyperstimulation whenever we are giving some letrozole or some other medication to stimulate the ovulation.
Okay. So if you are having this in vitro fertilization, generally you'll be giving some FSH or something.
Hmm.
So these will be more responsive. The other thing, if you remember, we discussed one study which talked about a Chinese study. If your estrogen levels are very high during the in vitro fertilization, there is a risk of developing metabolic complications and diabetes in the offspring. And there they talked about if the estrogen is high, use a freeze-all strategy. Don't go for immediate transfer. And that, so PCOS, what is the estrogen level in PCOS?
Hyperestrogenic.
So it's a hyperestrogenic situation also. So that is something which is going to affect.
So major key changes, probably a AMH in adults, which could be done. The recommendation of the anti-obesity medications like GLP-1 agonist. Inositol is a +-1, still not clear about the potential role of inositol in the treatment of PCOS. Progestin only pill for the in place of combined oral contraceptive pill. Psychological issues, they had been addressed properly this time, that we should be more careful about counseling the parents as well as the children regarding the psychological issues of the children, and some future biomarkers like 11 oxygenated steroids they had mentioned in the new guidelines.
So thank you, Dr. for a wonderful discussion on PCOS. This was quite informative. We'll quickly go forward to Turner syndrome, which again is an important indication. And Dr. Nimisha will talk about the latest Turner syndrome guidelines.
Thank you, sir. As we all know, the diagnosis of Turner syndrome is based on female phenotype with one X chromosome and complete or partial absence of second sex chromosome with one or more than one clinical manifestation, which includes the major criteria required as only one, and two of the minor criteria is required. Those who are not considered to be Turner are women aged more than 50 years with less than 5% of 45X mosaicism, one X chromosome and deletion of second X chromosome distal to XQ24, and 45X and 46XY mosaicism with no female external genitalia. The gold standard of for diagnosis is karyotype. Minimum 30 metaphyses has been studied in this guideline. Detecting mosaicism, additional metaphyses to be screened, and for rapid test result, microarray FISH PCR can be used, and confirmatory being the chromosome analysis. And 45X chromosome with signs of virilization, we should screen for Y chromosome using FISH.
So this is the very important part that you talked about, that somebody who has got a 45X chromosome with virilization, or let's say a marker chromosome, there only you should do a Y chromosome. Why don't you do FISH in everybody? You will pick up more cases of Y line.
It should be the pretest probability whether it is high or not. If it is a present virilization of there, then unnecessarily, otherwise it will be increasing the cost of the.
No. So what you're trying to say is fine, but let's say if you identify Y line on routine screening and you identify Y line with virilization, which will be more likely to develop gonadoblastoma. So those who have virilization, those who have marker chromosome, those are macro, because your risk has been determined based upon the chromosome karyotypically detected, not FISH detected. So FISH maybe small line is there flying, it doesn't make any difference. But if you have on the chromosome, then it will become more important. So that's a very important point. Carry on.
For suspect of Turner syndrome in fetus is abnormal ultrasound features, which include increased knuckle translucency, frank cystic hygroma. The screening test is NIPT, and the confirmatory being chorionic villus sampling, chordocentesis, amniocentesis, or postnatal karyotyping to be done.
So what do you do in NIPT? NIPT is a
non-invasive.
What is done there?
Amniotic fluid.
So it's the
Free DNA, free circulating DNA.
So in the mother's blood, some of the fetal DNA is circulating, that is being studied. So it's a very important point you put that if you find somebody, we get people referred that NIPT Turner positive. In that case, you say, okay, we do not consider this to be a final testing. It should ideally be done using a CVS or a chordosynthesis. And even if you are identified prenatally, you should always do a postnatal karyotype also in the child. Yeah.
High risk NIPT for Turner syndrome, if found, we should do detailed ultrasound. If found normal, we should do invasive diagnostic tests. And if that is normal, karyotyping for maternal sex chromosome aneuploidies should be done. According to 2016 guidelines, they say for diagnosis, 20 cell metaphysis to be studied. Here, 2024, the guideline mentioned minimum study of 30 metaphysis for Turner syndrome. And for rapid result, we can go for FISH, microarray, and PCR, but the confirmatory still being the karyotype. Growth hormone, we should start as early as possible, less than 2 years of age, those in which short stature is present and rate of growth is below normal or declining. In more than 12 years, with short stature and growth potential is still present. It should be continued till 14 years of age, bone age is more than or equal to 14 years, or height velocity has decreased to less than 2 centimeter per year. The dose is supraphysiological with 45 to 50 microgram per kg per day and maximum up to 68 microgram per kg per day.
I think the big change might be in the first part. People used to talk about, first of all, they said when they are short by the normal growth chart, less than 5th percentile. Then the talk was a fall from the chart, even the growth velocity is less, but less than 2 years is a bit early based upon the toddler studies which were done. But then again, there is a bit of a doubt whether these studies really implemented resulted in an increased height in the final height. So less than 2 years, it's usually very difficult for in India to get anybody less than 2 years, but that's something which they are suggesting.
More than 12 years with short stature and open epiphysis, we can use low dose estradiol along with growth hormone. To monitor the growth, we should measure height every 6 months on Turner specific growth, Turner syndrome growth chart. IGF-1 level should be monitored annually and should be kept within normal range for age, pubertal stage, and sex. And if IGF-1 is found persistently high, we should decrease the dose
So
of
they have given a criteria like how much
Yes.
SDS?
No, sir, they have.
Because
It is mentioned in previous class.
plus 3 SDS was considered.
Adverse effects, there is increased risk of intracranial hypertension, slip capital femoral epiphysis, and lymphedema in Turner syndrome with growth hormone treatment. Low dose estrogen supplementation in prepubertal years to promote growth is not recommended. The
That's
major
very important because there was a big trial from NIH which talked about injectable estrogen at a very low dose, talking about increasing growth. But then there's been no such studies. So this has now been clearly said that don't use low dose estrogen. That's very important.
The major changes were earlier guideline recommends of starting growth hormone at around 4 to 6 years of age. 2024 guidelines recommend as early as possible and can be started as young as 2 years of age. Uh, the earlier guideline recommend using of oxandrolone from the age of 10 years or older. In 2024 guideline, it is no longer recommended because of side effects.
Nobody uses Oxandrolone anyway, so it's been removed already.
Puberty, for puberty, we should monitor FSH, LH, and AMH at 8 to 9 years and yearly till 11 to 12 years. Estrogen replacement therapy should be started at 11 to 12 years of age with elevated FSH found to be FSH elevated found on 2 sequential measurement. Low dose estrogen replacement is considered, which is increased slowly to adult replacement dose over 2 to 4 years. Target serum E2 concentration is 100 to 150 picogram per ml in adult, and transdermal route is preferred. Estrogen should be continued till age of menopause, which is 50 to 55 years old, and we should monitor breast development. Uterine ultrasound should be done. Bone density, height, and serum E2 concentration should be measured during treatment. In females with abnormal bleeding, monitor uterine growth and serum E2 concentration to adjust dose. We should add progesterone after breakthrough bleeding occurs, which usually happens after 18 to 24 months of estrogen exposure, or endometrial thickness is 4 to 8 mm. We can use micronized progesterone alone or combined E plus P. Advantages: protect from endometrial hyperplasia and carcinoma and provides regular withdrawal bleeding.
2024 guidelines suggest combined sequential use of E plus P and suggest multiple assessment of treatment being given. Most of the Turner syndrome are mostly unfertile. Less than 10% have spontaneous conception. Counseling should be done by fertility specialists, and we should monitor AMH annually to check for the fertility. And those who wanted pregnancy, controlled ovarian stimulation and oocyte cryopreservation should be done, and it is not recommended in premenarchal females. For cardiovascular health, suspect Turner if left-sided congenital heart disease is present in fetus. Do fetal echocardiogram prenatally if there is high suspicion of Turner. If prenatally diagnosed or suspected Turner syndrome, we should do TTE as early as possible. And TTE should be done at the time of diagnosis in all children and adults. There are multiple complications associated with Turner syndrome, like diabetes, osteoporosis, hearing loss, hypertension. So we have to monitor them regularly. Ophthalmological screening should be done at 6 to 12 months of age or at the time of diagnosis. And then follow-up should be done if initial examination is abnormal or new visual complaints arise. Hearing should be done at the time of diagnosis, then annually till 5 years of age, and in childhood every 2 to 3 years, and in adult every 5 years it should be followed. Dental examination should be started at when first teeth eruption occurs, then annually. Dermatology, it should be evaluated annually. Renal, USG, KUB should be done at the time of diagnosis and follow up with urine analysis annually if the abnormality is present in earlier screening. Liver disease screening should be started at 10 years of age with AST/ALT monitoring and then annually. Cardiac should be done with TTE at the time of diagnosis. Anemia should be using a hemoglobin level should be screened during adolescence, then every 1 to 2 years. Bone health, we have to measure vitamin D levels starting at the age of 9 to 11 years, then monitor it every 2 to 5 years, and DEXA scan 21 years of age starting, and then monitor every 5 to 10 years. Skeletal anomaly should be done annually with physical examination. Celiac examination should be done with TTG using 2 years of age, then every 2 to 5 years. For thyroid, TSH should be done every 2 years, every 1 to 2 years, and should start at 2 years of age. Diabetes, 10 years of age, we should start screen for diabetes using HbA1c or fasting blood glucose, then followed up annually. And for fertility, using FSH, LH, and AMH, start screening at 8 to 9 years and follow up annually till 11 to 12 years. Take home messages. Karyotype is mandatory for diagnosis. Screen for comorbidities. Early initiation of growth hormone. And HRT, we can preferably combine E plus P pill should be used. Thank you.
Nimisha, for the wonderful summary. So we have got three very good guidelines. One talked about long-acting growth hormone, which is at early stage, but something which we have to look forward to. Then we talked about PCOS and new guidelines, particularly with regards to the role of newer agents and other scenarios. And Dr. Nimisha talked about Turner's in that regards. All of you can go and have a look at our website, our courses, and the mobile application. We'll see if there are any particular questions which are there. So, Dr. Priska Amalo is asking, how effective is laser therapy for hair removal? Now, laser therapy generally is effective, but we have to take care of hyperandrogenism first. So, we generally talk about correcting the disorder and then we talk about doing it later on. Our OCP is recommended for all adolescents with PCOS. I would say the primary treatment, if you are very sure that this is a sort of a polycystic ovarian syndrome, then estrogen progesterone is the cornerstone of treatment, which you have to think of. And I would say when you're using estrogen progesterone, you should also be using metformin in that scenario. Both are important. The only scenarios where you can think of a progesterone only pill is if there is a predominant anovulatory component without hyperandrogenism, because it's not going to help you out on that. And second, if there is a contraindication of estrogen. So something which you should be very careful about is hypertension, thrombotic episodes, and then other features which may contraindicate. Otherwise, you should definitely use that in that regards. So I think this was interesting discussion, and we will be having more such guidelines reviews subsequently as they